I'm sure people have heard about the price of HCV medications, which is very high and is always brought up. And it certainly is an issue. They are cost effective. We have multiple studies now that show they're cost effective. That doesn't change the fact that they're still expensive, and there's a difference there between the actual cost of the drugs and whether they're cost effective. We're dealing with that. I think in many places we're seeing access improve in that insurance payers are loosening the reins a little bit on the HCV medications. In other words, they're decreasing the number of hoops we have to jump through essentially to get medications approved. Here in California, we're now down to an F2 stage of fibrosis for our Medicaid patients, meaning lesser fibrosis, they can still qualify for getting medical treatment for their Hep C with the new medications. Before July of this year, we were at F3, F4. So again, it's gradually loosening up in California, although a point of emphasis is obviously for anybody that's watching this is you really need to know what's happening where you're practicing, because it varies tremendously across the United States. From some areas where almost everybody can get access to areas where it's very difficult even for patients that might have cirrhosis to get access to the medications. It's not terribly transparent actually in a lot of settings, so it's hard to know, and again, as I mentioned, it varies. But in generally it varies by state. So it's a state, the state that administers kind of their money or their Medi-Cal programs, or in California it's Medi-Cal, or their Medicaid programs in other parts of the country. So it's generally the state manages and sets those criteria. Private insurance companies set their own criteria. They look at the evidence and decide where they're going to draw the line kind of in terms of who can access therapy and who cannot. Private insurance is probably the most unpredictable because in some programs access is very good, others it's not, but it's not standardized across private insurance. Medicare traditionally has been the best access for us, and I think that generally holds true across the country, where patients who have Medicare, we really don't have a hard time getting medications for almost any patient we want to treat with hepatitis C. And again, traditionally Medicaid has been the most restrictive, but again, we're seeing that loosen up as well. Probably if we go back maybe even 5 years ago, the discussion would have been that patients don't respond very well to therapy, because this would have been a time even before we had the first direct-acting antivirals or antivirals that specifically target the virus, so we're using interferon and ribavirin. And specifically at something like ID week, or a place where we talk about HIV hepatitis C co-infection, there was a significant difference in how patients with co-infection would respond to therapy when we were talking about just interferon and ribavirin. So the poor tolerability of that regimen combined with worse treatment efficacy in patients with HIV and Hep C really led to a period where we weren't very enthusiastic about treating patients and didn't treat a lot of them. Over the last couple of years, the theme has become the direct-acting antiviral-based regimens that are interferon-free work great, and we now come to expect a cure rate of 90 to 95% in almost every population when we're looking at a study, and if it's not that high, it's a disappointment now. The other major theme that's kind of, again, specific to ID week maybe, or at least HIV hepatitis C co-infected patients, where we probably talk about that a little more, is that with these DAA therapies now, it seems a co-infected patient, for all intents and purposes, responds just as well as somebody who has HCV alone. I guess the final theme that's now re-emerging is resistance. It's a topic I've been interested in, and I think we had a period of time after the DAAs first came out where we worried about resistance. Then after we got the very potent interferon-free DAAs, we started saying, oh, maybe resistance doesn't matter. And now just at the last couple scientific meetings, the European liver meeting, in particular, we heard of some studies of patients who had failed DAA therapy, so failed the interferon-free, very potent regimens. And admittedly, this is a small population in general, again, because most studies were expecting 90 to 95% of patients are going to be cured. But there is that 5 to 10% that fail. And what we learned or saw for the first time at the European liver meeting was that if those patients who failed, if you tried to retreat them with the same regimen and they went into that regimen with resistance to one of the components of the regimen, they did not do very well. It was about a 70% cure rate, which again, doesn't sound horrible, but it's not in line with what we expect now out of DAA regimen. So I think going forward, at least for the next couple years, resistance is going to have a little bit of a reemergence while we're waiting for some very potent regimens that now combine 3 drugs with 3 different mechanisms of action that may finally get rid of resistance, but we'll see. As I mentioned, I've been involved in clinical trials, and there's still some of that going on, but one of the things we're excited about here at UCSD, certainly not unique necessarily, is taking these fabulous medications and really trying to deliver them to the populations that need them most. And in the United States, as well as in much of the world, certainly in the United States, we think most of new HCV transmissions are through injection drug use. And we have these great medicines that we can now start to use as kind of a tool to see if treating somebody with active hepatitis C who also happens to inject drugs, we can eliminate the hepatitis C from that person and then prevent them from continuing to transmit the virus to other people. We're interested in looking in active injection drug users and trying to deliver these therapies in a controlled fashion to see if we can actually at least model what might happen to future infections. The ultimate goal would be to try to eliminate hepatitis C from at least certain populations in localized areas as kind of a proof of concept that then could serve as a broader impetus to deliver more therapy to injection drug users. Again, the population that needs it that right now is not getting a lot of treatment with these very effective regimens.